Great, thanks. So I'm talking about urologic emergencies in pregnancy. I'll begin by reviewing the physiologic and anatomic changes of the GU tract associated with pregnancy. Then I'll review the incidence and natural history of urolithiasis in the pregnant patient before focusing on the indications for non-surgical and surgical management of stone disease during pregnancy. Next, I'll go over the clinical implications of UTIs and asymptomatic bacteriuria during pregnancy, as well as the current treatment guidelines for bacteriuria during pregnancy. I'll also briefly talk about the management of placenta percreta, hematuria, and urinary retention in the pregnant patient. And finally, I'll review the management of AML and Pheochromocytoma, two neoplasms that can present as urologic emergencies during pregnancy. Before we go any further, I'd like to present a case that occurred last month at BC Women's Hospital, which highlights some of the unique challenges in treating pregnant patients. It's a case of a 37-year-old woman, 34 weeks pregnant, that was admitted with fever, chills, and left flank pain. She was otherwise healthy, on no medications, and had an unremarkable antenatal course until presenting to hospital. An ultrasound was performed after admission, which demonstrated some mild left-sided hydro. The right kidney was normal, with no hydro noted at that time. And as we'll soon see, typically the physiologic hydro of pregnancy is more pronounced on the right. So maybe her ultrasound was a bit unusual, but maybe just in keeping with an acute pyelo, and no stone was identified at that time. Our service was consulted with the question of whether or not she had a stone. Since none could be seen on the ultrasound, we recommended she be treated as an acute pyelo with IV antibiotics and recommended re-imaging if she didn't respond quickly to treatment. Unfortunately, her condition deteriorated that night following our consult, and she was transferred downtown to St. Paul's with urosepsis. There she was briefly admitted to the ICU and treated with a course of IV meropenem, and she'd had a positive urine culture. Complicating things further was she had evidence of consolidation on chest x-ray, and she was felt to maybe have a pneumonia. She had a repeat ultrasound, and again there was hydro noted on the left kidney, but again no stone was seen. Her sepsis resolved, and she ended up being transferred back to the Women's Hospital. However, she still had ongoing flank pain, and she was requiring IV morphine for relief. Our service was contacted again when she returned to BC Women's, given this ongoing left flank pain. She had yet another ultrasound, and this time an 11-millimeter stone was seen in the proximal left ureter that hadn't been picked up on the multiple ultrasounds she'd had previously.
What did her original urinalysis show?
She had some pyuria.
No red cell?
Yeah, there was a bit of microscopic hematuria as well.
Should have thought it was stone right off.
Yep. So again, after having this ultrasound, finally the stone was picked up. She was transferred back downtown to St. Paul's, and Brian Mason did Urological and treated her successfully with uncomplicated laser lithotripsy, and he did it without fluoro. So I think this case highlights some of the pitfalls in accurately diagnosing stones in pregnant patients, where we rely principally on ultrasound rather than CT due to our fear of exposing the developing fetus to ionizing radiation. So let's look now at some of the physiologic changes with pregnancy. As outlined in the graph here, cardiac output increases 30 to 50% over the course of pregnancy. At the same time, progesterone and prostacyclin decrease systemic vascular resistance, and in the third trimester, the uterus compresses the great vessels, decreasing venous return. Total blood volume increases by 25 to 40%, but plasma volume increases by up to 50%, causing a relative hemodilution and physiological anemia. In this state, a pregnant patient can lose up to 2 liters of blood before showing any changes in heart rate or blood pressure. One of the most significant GU tract changes in pregnancy is dilation of the upper urinary tracts, which occurs by the 7th week of gestation in up to 90% of pregnant women and may persist for up to 6 weeks postpartum. This physiologic hydro is thought to result from both hormonal and mechanical factors. The expanding uterus directly compresses the ureters, while progesterone inhibits ureteral smooth muscle contraction, causing further ureterectasis. Ureteral dilation is usually more pronounced on the right side because of dextrorotation of the uterus, while the left ureter is more protected by the sigmoid colon. Occasionally, this physiologic hydro may be painful enough to require analgesia, or relief by positioning the patient left side down. Placement of a ureteral stent or nephrostomy tube may even be required for persistent symptoms. There's a study from the British Journal of Obstetrics of over 30,000 women that delivered at a single institution in the UK over 3 years, which showed that only 56 women required admission for symptomatic hydro, and of those admitted, only 7% required intervention with stenting. With increased cardiac output and decreased systemic vascular resistance during pregnancy, there's a concomitant increase in renal plasma flow and GFR. In some studies, GFR has been shown to increase up to 40 to 65% in comparison with pre-pregnancy values. The increased GFR results in a decrease in average serum creatinine and an increased filtered load of calcium, uric acid, citrate, and other factors that we'll look at more closely when we discuss the incidence of stones in pregnancy. In the lower urinary tract, the bladder is distorted by direct compression from the gravid uterus on the dome, with the bladder itself displaced anteriorly. Increased circulating estrogen and progesterone levels cause hyperemia and congestion of the bladder mucosa. There's also a decrease in the presence of the bladder neck to alpha stimulation, and with decreased pelvic support of the urethra, there may be increased rates of incontinence noted during pregnancy as well. So let's move on to look at the incidence of kidney stones during pregnancy. As mentioned earlier, the increased GFR seen with pregnancy leads to an increase in the filtered load of urinary calcium, uric acid, oxalate, and sodium. Hypercalciuria is also driven by an increase in the intestinal absorption of calcium due to increased circulating levels of vitamin D. The physiologic hydro of pregnancy contributes to urinary stasis in the upper urinary tracts. These lithogenic factors are offset by the increased filtered load of inhibitors of stone formation, such as citrate, magnesium, and glycosaminoglycans, as well as by the increased urine volume associated with the increased renal plasma flow. The balance of lithogenic and protective factors leads to an equivalent incidence in stone formation in pregnant and non-pregnant women of childbearing age. Symptomatic stones occur in approximately 1 in 1,500 pregnancies. The true incidence is unknown, given that usually only the symptomatic stones are diagnosed, and the reported incidence varies from as high as 1 in 250 to as low as 1 in 3,000 in the literature. Stone formation occurs equally on the left and right, but are found twice as often in the ureter compared to the kidney. Most incidents of symptomatic stones occur in the second or third trimester. Looking at stone composition, a retrospective review from Ross et al. In 2008 showed almost exclusive calcium stone formation with the majority composed of calcium phosphate. This is in contrast to the general population, where calcium oxalate stones are the most common, and the increased urinary pH of pregnancy likely contributes to this difference. As with non-pregnant patients, pregnant patients typically present with nausea, vomiting, hematuria, and flank pain or abdominal pain during an acute stone episode. However, a high index of suspicion is necessary to diagnose renal colic in pregnancy, as anatomical changes may alter the localization and radiation of abdominal pain. And as we discussed earlier, the diagnosis of abdominal pain caused by acute ureteral obstruction can be difficult to discern from physiologic hydro. The importance of accurate diagnosis and appropriate management of stones results from the additional risk of obstetric complications, which can include hypertension, preeclampsia, or the onset of premature labor. With that in mind, let's turn our attention now to the diagnosis of stones during pregnancy. The most important consideration is the risk of ionizing radiation, which may induce mutagenesis, teratogenesis, or carcinogenesis in the developing fetus. This in turn may result in intrauterine growth retardation, organ malformation, mental retardation, or even perinatal death. The extent of damage to the developing fetus depends on the gestational age and the radiation dose involved. The dose is obviously dependent on the type of study, but it's also affected by the distance from the collimator to the fetus and the gestational age, with less radiation absorbed by the fetus later in pregnancy. The effects of ionizing radiation are most harmful during the first trimester, when organogenesis occurs. Shown at the bottom of this slide is a statement from the Guidelines for Diagnostic Imaging During Pregnancy from the American College of Obstetrics and Gynecology, which states that the exposure to less than 50 milligray has not been associated with an increase in fetal anomalies or pregnancy loss. Overall, however, there's no consensus on safe radiation exposure limits during pregnancy. There's an older study from the New England Journal which showed that exposure of 1 centigray in utero can increase the relative risk of leukemia by 1.6 times in childhood and increase the risk of all cancers 3.2 times. A more recent study from the British Journal of Urology showed that doses less than 5 centigrade do not cause IUGR or other fetal anomalies, which is in keeping with the statement from the American College of Obstetrics and Gynecology. The table shown on this slide comes from a study by McCullough, which looked at certain fetal adverse effects from radiation exposure. The majority of the data from the human studies comes from the atomic bomb survivors from Hiroshima and Nagasaki, 500 of whom received a Conceptus dose of greater than 10 milligray. This table shows that effects such as IUGR, organ malformation, mental retardation, and childhood cancer occur with exposure of 100 milligray or more. Looking now at the radiation dose from X-ray and fluoroscopy, this table again comes from the work by McCullough. The radiation dose to a fetus from X-ray or fluoro depends on the thickness of the patient, the direction of the projection, the depth of the fetus from the skin surface, and X-ray technique factors. The dose of the fetus may vary by a factor of 10 for a specific examination or projection. For example, the estimated fetal dose in early pregnancy from an AP X-ray of the abdomen is about 1 milligray, shown in red here. This can be compared with the fetal dose from naturally occurring background radiation of approximately 1/2 to 1 millisievert for the entire period of gestation. Before we look at CT and ultrasound, I'll briefly mention the use of limited IVP, which is now more of historical interest. It does offer the advantage of superior visualization of the ureters compared to ultrasound and less radiation exposure than conventional CT. The 3-shot IVP protocol was actually described by Dr. Stuthers in a study that she did here at the former Grace Hospital, looking at all cases of renal colic in pregnant patients over a period of 12 years. This involves a scout film and subsequent films at 30 seconds and 20 minutes. In her study, the use of IVP accurately identified stones in 16 of 17 pregnant patients with colic. Looking at CT now, the gold standard in non-pregnant patients. Once again, this table comes from McCullough and looks at the radiation dose to the fetus from CT. Obviously, it's associated with higher levels of radiation exposure than X-ray. However, the fetal dose could vary by a factor of 2 to 4 for a specific exam, depending on the thickness of the patient, the depth of the uterus, and other factors. Outlined in red are the doses with conventional CT of the abdomen and pelvis, and with a CT stone protocol from their institution. The dose from the stone protocol is estimated at 10 milligray. What about low-dose CT? The fetal dose from these protocols may be as low as 4 milligray. The sensitivity and specificity for stone detection with low-dose CT has been shown to be maintained when compared to conventional CT. The study shown on this slide is from Jellison, and it asked radiologists to look at scans with stones in the ureter varying in size from 3 to 7 millimeters with varying levels of radiation. Even at low doses, the radiologists were able to accurately identify stones with excellent inter-observer agreement. Looking specifically at the use of low-dose CT in the setting of pregnancy, a study by White of 20 pregnant patients showed an average radiation dose of about 7 milligray, which is significantly less than the 50 milligray threshold put forward by the American College of Obstetrics and Gynecology. 13 of the 20 patients in this study were found to have stones. 5 were treated with urology, 2 with stent placement, and 2 were treated postpartum, and 4 were managed conservatively. Finally, what about the use of ultra-low-dose CT? The ultra-low-dose CT protocol here at VGH is not yet in routine clinical use. The radiation dose is only 0.28 millisieverts, which is less than the average exposure from the background radiation over the course of a year. I spoke to Dr. Zerowich, and ultra-low dose CT has not been used on a pregnant patient at our institution, and they still consider ultrasound and MRI to be their first and second line exams for renal colic in the pregnant patient. So in conclusion, for radiation, a threshold of 50 milligray probably poses negligible risk of pregnancy loss or fetal anomalies. And the risk posed by a study with ionizing radiation may be worthwhile if it will significantly change your management. Let's change gears a bit and look at ultrasound. Ultrasound is still considered first line, as I mentioned, and offers the advantage of not posing any risk of ionizing radiation while allowing excellent visualization of the parenchyma and easy identification of hydro. However, the disadvantages, as we saw with the case I presented, are difficulties with visualizing the ureters and in differentiating hydro secondary to ureteral obstruction from a stone from the physiologic hydro of pregnancy, with reported sensitivities varying from 38 to 95% of the literature. There are ways of improving the diagnostic accuracy of ultrasound with techniques such as the use of color Doppler for the identification of ureteral jets, transvaginal ultrasound, and the calculation of renal resistive indices. Shown on this slide is a study from 2009 by Andreo and McMahon of 262 pregnant patients with renal colic. 144 of these patients were ultimately found to have a stone, with 56% identified by ultrasound. If the ultrasound interpretation was further modified using features of upper tract obstruction, such as hydroureter extending below the pelvic brim, the asymmetric absence of ureteric jet, or an elevated resistive index, the accuracy of ultrasound to predict the presence of a stone improved significantly to 72%. Looking specifically at the use of resistive indices, work by Shokir studied 22 pregnant patients with obstructing calculi. All have been confirmed with limited IVP. And the difference in the resistive index between the obstructed and non-obstructed kidneys was calculated in each of these patients, and then compared to the differences seen in cohorts of pregnant patients without stones and non-pregnant women of childbearing age. The difference in resistive index was significantly more pronounced in the pregnant patients with obstructing calculi by a factor of 10. Transvaginal ultrasound offers the advantage of better visualization of the distal ureter. In a small study of 13 women with renal colic by Lang, 13 of 13 distal ureteric stones were visualized with transvaginal ultrasound, compared with 2 of 13 when transabdominal ultrasound was used alone. 6 of these 13 patients in the study were pregnant. When results are equivocal, MRI without contrast is safe, effective, and comparable to CT in terms of accuracy, and is now considered second line during pregnancy when it's available. It visualizes the stone as a filling defect and can evaluate secondary findings of obstruction. However, the stones themselves are not seen directly, as calcium is poorly visualized, and access can be an issue in Canada. A study by Spencer in 2004 looked at the use of MRI in 24 patients with symptomatic hydro. 7 of these patients were found to have stones, and in their study they described the so-called double kink sign shown on the slide here, which they used to distinguish patients with distal stones from physiologic hydro. So it's a constriction of the ureter at the pelvic brim and then again at the UVJ, leaving the standing column of urine in the pelvic ureter seen here. They concluded that MRI was safe and effective in the setting of renal colic in the pregnant patient. Moving on to management now. As in the treatment of stones with non-pregnant patients, careful consideration of the size and location of the stones is necessary before choosing a treatment strategy. With pregnant patients, additional consideration must be given to the gestational age of the fetus. According to the work by Stuthers, about 2/3 of pregnant patients with stones will spontaneously pass them during pregnancy, with 50% of the remaining patients passing their stones postpartum. Intervention is only required about a third of the time. Given that the majority of patients do not require any intervention, initial management is conservative with analgesia and hydration. Opioids should be used as first-line analgesia. NSAIDs are avoided due to the risk of spontaneous pregnancy loss in the first trimester, premature closure of the ductus arteriosus, and fetal pulmonary hypertension. Before we discuss the use of medical expulsive therapy, I wanted to show the FDA fetal risk categories, which can be used as a guideline for which medications are safe for use in pregnancy. To quickly summarize, Category A drugs are those which have been proven safe for use in pregnancy with well-controlled studies, while Category B meds have not been shown to pose a risk to the fetus in animal studies without adequate studies in pregnant women. With Category C, animal studies have shown an adverse effect on the fetus, and there are no well-controlled studies in humans, but potential benefits may warrant use of the drug. Category D drugs have evidence of risk to the fetus, but may be used if necessary. Category X is reserved for drugs contraindicated for use in pregnancy. Medical expulsive therapy can be considered as an adjunct to a trial of spontaneous passage in pregnant women. Alpha blockers are Category B drugs, meaning they have not been studied in humans but have been shown to be safe in animal studies. Calcium channel blockers are Category C, but are sometimes used in the treatment of gestational hypertension, and they're also considered safe. As with the non-pregnant population, some are not candidates for trial of passage and fail conservative management. If fever, infection, or obstetric complications are present, then intervention is indicated. Other indications for intervention include renal failure, obstruction of a solitary kidney, or bilateral obstruction, with relative indications including refractory pain, intractable nausea and vomiting, stones greater than 1 centimeter, or non-diagnostic imaging. If a procedure is needed, an experienced multidisciplinary team should be involved. Temporary drainage with a stent or nephrostomy tube versus definitive treatment with ureteroscopy is the next decision point to be made in terms of management. Previously, definitive management was thought to be too dangerous, but over the last 2 decades it has become more common with improvements in ureteroscopy. Shockwave lithotripsy is contraindicated as the shockwaves are thought to be harmful to the developing fetus, with risks of placental separation and bleeding as well. There's a study from the British Journal of Urology in 1999 that looked at over 800 women of reproductive age that underwent USWL. 6 had inadvertent S-wall while pregnant, and all went on to deliver children with no detectable anomalies. PNL is contraindicated given the risk of fetal exposure to ionizing radiation with extended fluoro and with difficulties positioning the pregnant patient. When it comes to temporary drainage, ureteral stent placement may be performed under local using ultrasound or under general anesthesia with limited fluoro. However, indwelling ureteral stents may worsen irritative lower urinary tract symptoms and may already be present in pregnancy. Furthermore, rapid stent incrustation is common in pregnancy and has been attributed to the increased hypercalciuria and hyperuricosuria we discussed earlier. Therefore, stents should be trained every 4 to 8 weeks in pregnant patients, and for these reasons, some would advocate nephrostomy tubes over the use of stents. Nephrostomy tubes can also be placed with ultrasound guidance under local. Encrustation can also be an issue, but nephrostomy tubes offer the advantage of easier exchange or flushing if this occurs. Nephrostomy tube placement may be appealing in patients with obstruction earlier in pregnancy to avoid the need for multiple stent changes. Also, if there's a large stone burden, nephrostomy tubes can assist with future access for definitive treatment later with PNL. The disadvantages of nephrostomy tube include the risk of bleeding, need for an external appliance, and bacterial colonization of the drain. Because of the disadvantages of temporary drainage, definitive management with ureteroscopy is considered a reasonable option. Ureteroscopy can be done under spinal or general anesthetic, and good outcomes can be achieved without the need for radiation, as we saw with our case earlier. In 2009, Siemens performed a systematic review and meta-analysis of 14 reports of ureteroscopy during pregnancy in over 100 patients, which compared complication rates between the general female population and in pregnant patients. They showed that there was no significant difference in the ureteral injury and UTI rates. There are several more recent published case series reporting acceptable safety profiles and good efficacy for ureteroscopy during pregnancy. This table summarizes some of those studies looking at complication rates with the use of ureteroscopy. Highlighted in red is the largest series, which as mentioned comes from the meta-analysis by Siemens. The overall complication rate was 8% and included 1 ureteral perf, 1 patient with premature contractions, and 5 UTIs. In the series by Johnson, also shown in red, the authors stress that a multidisciplinary approach is critical, as they did have 2 patients go into premature labor and 1 delivered early. So let's move on now and look at UTIs in pregnancy. Infections of the urinary tract during pregnancy can cause significant morbidity or mortality for the mother and fetus. Overall, UTIs are as common in pregnant patients as they are with non-pregnant patients, with an incidence of 4 to 7% reported in the literature for asymptomatic bacteriuria, acute cystitis, and acute pyelonephritis. However, the risk of developing acute pyelo during pregnancy is much higher. Because of the risk of acute pyelo and its associated complications for the mother and fetus, current guidelines recommend that all pregnant women be screened at approximately 16 weeks of gestation for bacteriuria. Asymptomatic bacteriuria is defined as the presence of 100,000 colony-forming units per milliliter of urine in a properly collected specimen without concomitant symptoms. Urinary tract pathogens in pregnant women are similar to those in non-pregnant women. E. coli is the most common, followed by Klebsiella and Enterobacter. Risk factors for acquiring bacteriuria during pregnancy include advanced gestational age, low socioeconomic status, multiparity, and sickle cell trait. A Cochrane review from 2007 looked at the effect of antibiotic treatment for asymptomatic bacteriuria on persistent bacteriuria during pregnancy, the development of pyelo, and the risk of low birth weight and preterm delivery. Randomized trials comparing antibiotic treatment with placebo or no treatment in pregnant women with asymptomatic bacteriuria found in antenatal screening were looked at. 14 studies were included. Antibiotic treatment compared to placebo or no treatment was effective in clearing asymptomatic bacteriuria, significantly reduced the incidence of pyelo, and reduced the incidence of low birth weight. There's no consensus on the duration of treatment or the choice of antibiotic for the treatment of asymptomatic bacteriuria. A 3-day course will successfully clear bacteria about 75% of the time. Follow-up cultures are recommended to ensure adequate treatment and to rule out recurrent or persistent infections. The choice of antibiotics should obviously be effective, have low resistance patterns, and have good maternal and fetal safety profiles. Acute cystitis occurs in about 1 to 2% of pregnant women. The rate of progression of asymptomatic bacteriuria to symptomatic infection is 3 to 4 times higher during pregnancy. Symptoms of frequency and urgency are also common during pregnancy, which makes clinical signs and symptoms of UTIs in pregnant patients less reliable. The treatment of acute cystitis and asymptomatic bacteriuria are similar, with a 3 to 7 day course of oral antibiotics. Follow-up cultures, again, are important to ensure adequate treatment and to rule out recurrent or persistent infections. Low-dose prophylaxis can then be considered after the initial treatment. Acute pyelo occurs in 1 to 4% of pregnant women, and up to 20 to 40% of women with untreated asymptomatic bacteriuria will develop acute pyelo. Most cases occur in the 3rd trimester, when physiologic hydro and urine stasis are most pronounced. Early treatment can decrease the incidence of acute pyelonephritis by up to 90%. Symptoms of pyelo are similar to those seen in non-pregnant patients, with fever, chills, nausea, vomiting, and CVA pain. The significance of acute pyelonephritis in the pregnant patient are the risks it can pose to both the mother and the fetus. Maternal complications can include anemia, renal failure, ARDS, and sepsis. With respect to the fetus, acute pyelo may lead to prematurity, low birth weight, or even fetal mortality. Pregnant patients with acute pyelo should be hospitalized and treated initially with IV antibiotics. More than 95% of these patients respond within 24 hours of using amoxicillin and an aminoglycoside or cephalosporins. Appropriate oral antibiotics should then be given for 10 to 14 days. Low-dose prophylaxis with nitrofurantoin, amoxil, or Keflex has been shown to be effective in preventing reinfection. Just a quick reminder of the FDA fetal risk drug categories before we go on to discuss specific antibiotics and their use in the treatment of UTIs in pregnancy. This table here summarizes the antibiotics that are relatively contraindicated during pregnancy. These include fluoroquinolones because of the risk of damage to fetal cartilage development, sulfonamides because of the risk of neonatal jaundice and subsequent kernicterus, chloramphenicol for the risk of gray baby syndrome, erythromycin, which may cause maternal cholestasis, tetracycline, which may cause bone and teeth defects, and macrobid in the third trimester due to the risk of fetal hemolytic anemia in patients with G6PD deficiency. The penicillins and cephalosporins are considered safe and are both category B drugs according to the FDA. Okay, I'd like to spend the last few minutes talking about some rare urologic emergencies that occur during pregnancy. Acute urinary retention occurs in approximately 1 in 3,000 to 1 in 8,000 women. It often occurs because of the enlargement of a retroverted uterus with entrapment of the fundus below the sacral promontory. Fibroids or other uterine anatomical abnormalities can further predispose patients to urinary retention. Acute urinary retention classically occurs at 12 to 14 weeks of gestation and resolves by 16 weeks when the uterus grows out of the pelvis. Patients can be managed with temporary Foley or CIC. However, bimanual manipulation of the uterus to an anteverted position can also be attempted. Alternatively, a Smith-Hodge pessary, shown in the slide here, can be temporarily inserted to maintain uterine anteversion and to relieve pressure on the bladder neck. Hematuria during pregnancy needs to be differentiated from vaginal bleeding, and catheterization can help with this differentiation. Gross hematuria or microscopic hematuria in patients with risk factors need a complete workup with an ultrasound or MRI of the upper tracts plus cystoscopy. In the absence of any discernible organic causes, microscopic hematuria during pregnancy can be considered idiopathic as it is thought to result from physiologic renal changes during pregnancy. A full evaluation of the etiology of microscopic hematuria can be completed after delivery if follow-up urinalysis postpartum shows that it persists. One especially concerning cause of hematuria during pregnancy is placenta percreta, in which the placenta can invade through the uterus into the bladder. The incidence of abnormal placentation occurs in about 1 in 7,000 deliveries, of which placenta percreta comprises 5 to 7% of cases. Placenta percreta with bladder invasion is a life-threatening condition with the potential for significant bleeding. Only 22% of patients with placenta percreta present with gross hematuria, and often the diagnosis is made late after attempts to separate the placenta from the bladder. Pelvic ultrasound can help establish a diagnosis, and an elevated maternal AFP in the absence of fetal anomalies may also indicate placenta percreta. Cystoscopy can identify the placental lesion on the posterior surface of the bladder, but biopsy can result in significant bleeding and needs to be avoided. Attempts to separate the adherent placenta have been reported to cause massive bleeding. Most patients will go on to require hysterectomy with a partial cystectomy immediately following delivery. Conservative management with delayed hysterectomy with bladder preservation after medical management with methotrexate have been described in the literature. RCC is the most common urologic malignancy during pregnancy, followed by AML. Urothelial carcinoma in the bladder and in the upper tracts have been reported in pregnant patients, but rarely present emergently. Pheos and AML are two neoplasms that can present as urologic emergencies during pregnancy and are notable for their high potential for maternal or fetal morbidity and mortality. As mentioned, AMLs are the second most common renal masses identified during pregnancy after RCC. There's a female predominance of AMLs, and approximately 20 to 30% are found in patients with tuberous sclerosis. Although most AMLs are asymptomatic, patients may present with flank pain, hematuria, or hypovolemic shock related to bleeding. Massive hemorrhage during pregnancy is the most worrisome complication. It could even be fatal. Reports of rapid growth of AMLs during pregnancy suggest that a hormonal influence may play a role in the growth of these tumors. Furthermore, an increase in abdominal pressure and circulating blood volume may also increase the risk of rupture in pregnant women. The diagnosis can be confirmed using ultrasound or MRI without the need for ionizing radiation. Angio and embolization may be diagnostic and therapeutic in select patients. Generally, because of the increased risk of rupture and bleeding associated with AMLs greater than 4 centimeters, surgery is warranted before pregnancy. The management of symptomatic AMLs during pregnancy includes open or laparoscopic surgery, thermal ablation or embolization. Conservative management is feasible if the patient is asymptomatic or remains hemodynamically stable. Looking specifically at the safety of anesthesia during pregnancy, if surgery does become necessary, this is a study of 5,400 cases of non-obstetric surgeries in Sweden during pregnancy by Matsi from 1989, which showed an increased incidence of prematurity and low birth weight, which was felt by the authors to be due to the underlying diseases rather than the anesthesia itself. There's an older Canadian study by Duncan that looked at 2,500 women who underwent non-obstetric surgery during pregnancy, and they showed a small increased incidence of spontaneous abortion in the first and third trimesters. So the safest time to perform surgery in pregnancy is the second trimester. Finally, looking at Pheo, the overall incidence of Pheos diagnosed during pregnancy is 1 in 50,000. Although relatively rare, Pheos can cause significant morbidity because of the potential for severe hypertension. During pregnancy, patients typically present with hypertension, headaches, palpitations, and flushing, similar to non-pregnant patients. But in contrast to preeclampsia, patients with Pheo typically present earlier without the associated proteinuria that is seen with preeclampsia. Diagnosis is confirmed with 24-hour urine collection for catecholamines and metanephrines, and an ultrasound or MRI can help with tumor localization. A bright mass on T2 weighted MRI can help distinguish a Pheo from an adrenal incidentalloma. CT and MIBG scans are once again avoided because of the potential risks to the fetus. Definitive management of Pheo is warranted because of the risk of morbidity from uncontrolled hypertension. Elective termination of pregnancy may be offered if the Pheo is diagnosed early in pregnancy due to a historically high risk of fetal loss after surgery. However, improvements in the management of pregnant patients with Pheo have reduced fetal and maternal mortality rates from 46%, 55% to 4%, and 15% respectively. Pregnant patients should be stabilized medically before surgery with alpha blockade, followed by beta blockade if necessary. Laparoscopic adrenalectomy has been reported to be safe and effective during pregnancy. If Pheos are diagnosed later on in pregnancy, delivery in the third trimester should be performed after fetal lung development. C-section has also been associated with lower maternal mortality rates than vaginal delivery, and surgery can be performed at the time of C-section to avoid the need for 2 anesthetics. Okay, that's everything I've got. To summarize, the incidence of stones is similar in pregnant and non-pregnant patients. Ultrasound is still considered the first-line imaging modality, and most patients can be managed conservatively with analgesia, hydration, plus or minus an alpha blocker. If necessary, urologically is safe and effective. The overall incidence of UTIs is similar in pregnant and non-pregnant patients, but there is a greater risk of pyelo. Untreated bacteruria is a risk factor for developing pyelonephritis, and therefore screening is recommended. Cephalosporins and penicillins are safe for use in pregnancy to treat UTIs. Although rare, keep in mind the diagnosis of placenta percreta, which can present with gross hematuria. This condition usually requires hysterectomy and partial cystectomy. Acute urinary retention is rare, typically resolves by 16 weeks when it does occur. Pheo and AML are also rare, but can present as urologic emergencies during pregnancy with significant risk to the mother and fetus. The timing of any surgery depends on the clinical status of the patient and gestational age. All right, thanks to Dr. Afshar, who helped me put my slides together.